Greetings, everyone, and welcome to the EKG case for the week of September 29th, 2014. Before we get started, I want to send props out and greetings out to everyone who is attending the 8th European Congress on Emergency Medicine in Amsterdam. It's in full-blown swing right now, and I'm sure they have a great conference going on. I was really looking forward to making it out there. Unfortunately, just days before leaving, I unfortunately had to cancel my trip because of a family emergency, and I'm going to miss everyone out there, but I hope you all are having a fantastic time, and I really, really hope to catch up with you at a future conference. All recent and past friends that I always look forward to meeting at these type of conferences. So I'm sure it's a fantastic conference. Anyway, let's move on to this week's case. This week's case is actually homegrown. This was given to me just a couple of days ago by one of my good friends and close colleagues, Dr. Mike Winters, here at University of Maryland Medical Center. And Mike is our one of our critical care gurus and runs a very, very popular podcast on critical care in emergency medicine that probably many of you folks know. And he goes by the Twitter handle Critical Care Guys. And anyway, I wanted to show a photo of Mike just so everybody out there who follows him on Twitter and who knows his voice from the podcast might know what he looks like. So I Google searched Mike Winters, and this is what I came up with. First of all, apparently there's an actor out there by the name of Mike Winters, and there's also a major league umpire by the name of Mike Winters, and there's an Irish horse trainer by the name of Mike Winters, and there's an English comedian by the name of Mike Winters, and he goes on and on and on. Finally got tired of it, so I figured, let me just Google search Mike Winters guru, and I came up with Mike Myers, the love guru. So this is not Mike Winters, by the way. So then I figured, all right, I'm just going to go and Google search Mike Winters or Michael Winters, guru of resuscitation. And sure enough, the first hit I got is the Dr. Mike Winters, my colleague. And also I got a photo of his book, Emergency Department Resuscitation of the Critically Ill, that was published by Sept, and Mike is the editor-in-chief of this book. It's a fantastic book for anyone out there who wants a textbook on critical care. So anyway, just a few days ago, Mike was working in the emergency department and had this patient come in. It was a 55-year-old woman who was experiencing some chest pain, but more concerningly, she was diaphoretic. And as we've talked about before, whenever your patient sweats, it ought to make you sweat, right? Diaphoresis is a really, really bad sign in somebody who's having chest pain. Plus, the patient was hypotensive. The heart rate seemed to be relatively okay. You get a quick 12-lead EKG, and here's your EKG, and there's obviously some real problems going on with this 12-lead EKG. Now, the first thing I'm going to tell you to do, real important, is hit the pause button on your computer or your iPad or iPhone or whatever it is that you're looking at this EKG on. Hit the pause button. Do yourself a service by really trying to figure out what's going on. Don't just sit there and passively listen to the answers as they come flowing through the microphone here. All right, so everyone, ready? Go ahead and hit the pause button now. Okay, we're back, and hopefully you have a diagnosis. Some of you I know cheated, but just the same. So I've shown this EKG since Mike gave it to me just several days ago. I've shown this probably to about a half dozen, maybe as many as 10 people, and there's a common kind of pitfall that occurs here. So first of all, let's just take a look at the rhythm, right? Rate and rhythm, and you're going to take a look at the rhythm, and I think hopefully everybody here is noticing the fact that there are P waves that do not appear to be conducted. Certainly if you look in lead V1, which usually is our money lead, there's P waves that are not conducted. In this case, lead 2 is probably even better in terms of picking up those P waves. There's a P wave right there, and a P wave there, and a P wave there, and then there's a P wave that doesn't appear to be conducted. And then it starts over again. P wave, P wave, P wave, P wave, and that doesn't appear to be conducted, and so on. And these P waves map out, let me see, these P waves map out very nice and regularly, even across the dropped area. So I think we would agree that there's some type of AV block going on, not first degree, but there's either a second degree type 1 or Mobitz 1, or a second degree type 2 or Mobitz 2, or there's a third degree AV block. Now, people sometimes get confused about how to distinguish between the three. And whenever you're trying to distinguish between the various AV blocks, it's really, really simple because there's only one place that you need to look. Whenever you're trying to figure out, is this Mobus 1, or is this Mobus 2, or is this Mobus 3? Well, there's no Mobus 3, but this is third degree. All you need to do is just take a look at what is going on in the PR intervals. So if you take a look in the PR intervals, we'll start out where we were just a moment ago. There's a PR interval which seems relatively short, and then it's not abnormally short, but it's a little bit shorter than this one, and those are definitely shorter than this one. And then we move down here, and there's the P wave, and it's not conducted. And then you start all over again. There's a PR that looks pretty normal, and then it's longer and even longer, and then not conducted. And so there's a regular pattern of this happening all the way down. And so easy enough, when you see PR intervals that are gradually increasing and then a P wave is not conducted, that's very easy. That makes this a Mobus 1. Actually, I shouldn't put it like that. That makes it look like there's an MI. But Mobus 1 or second degree AV block type 1, also known as Wenckebach conduction. All right, so easy enough. Now, there's something else that's a little bit unusual that I don't want to make too big of a deal about here. But if you look, there's groups of 3 and groups of 3 and groups of 3, and you'll notice that the first beat in every one of these groups is just a little bit different. And if you look up in V1, you'll notice that the first beat is actually just a little bit wider than the other beats. So there's probably just some slight aberrant conduction going on in the first beat of every triplet there. But we're not going to make a big deal about that. It's just probably a little aberrant conduction. And the key thing here is that this is a Mobus 1. One of the people that I showed this to pointed out that it kind of looks like there's a delta wave or a slurring of the upstroke there, and so they're wondering maybe this is WPW, and that's a good pickup, but it's not WPW because to have WPW you need a short PR with the delta wave, and that's not a short PR, so let's not worry about WPW here. Okay, so remember, if you're going to call something WPW because you see slurred upstroke, there's got to be a short PR. If there's no short PR, then it's just a nothing slurring of the upstroke, a little aberrant conduction or artifact, whatever. Okay, so first thing, this is a Mobus 1. Okay, so let's take a look here at the rhythm. Second degree AV block type 1. The rate is probably about 65 to 70 or so. Now remember that this is a hypotensive patient. This is a really sick patient. The patient's got ischemic chest pain, and the patient has a Mobus 1 conduction. So my question here is, what do you want to do about the rhythm? If we follow ACLS, should this patient get atropine, or maybe you want to try a transcutaneous pacer, set up for a transvenous pacer. Maybe you want to go to epinephrine or dopamine. And, a lot of people might say, well, gosh, there's a Mobus 1 and the patient's got hypotension. So this is an unstable patient. I better go down the ACLS pathway and think about atropine or pacer. Well, they're hypotensive. Maybe one of these pressors will work. And the answer is actually none of the above. Because remember, ACLS talks about unstable tachycardias and unstable bradycardias. And this patient's ventricular rate is not bradycardic. This patient has a rate that's reasonable. And so this patient actually doesn't get any of those. When you see a hypotensive person and the rate is fairly reasonable, 65, the rate is actually closer to 70, well, this patient doesn't need emergent rate or rhythm control. This patient needs you to look for another cause of the hypotension, okay? So again, your treatment decisions in ACLS are based on the ventricular rate. And in this case, the ventricular rate's actually okay. It's about 70 or so. So this patient doesn't need emergent treatment of the rhythm. I'd probably get a pacemaker and put it near the bedside, have the crash cart nearby, but I'm not going to go give the patient atropine or pacing when the patient's ventricular rate's around 70, okay? So it's kind of a trick question, but it is a mistake that oftentimes people make. Remember, your decisions about treating via ACLS for unstable tachys or unstable bradycardias. Tachycardia, bradycardia is based on the ventricular rate. And in this case, the patient is neither tachycardic nor bradycardic, so acute ACLS management of the rhythm is not necessary. Just keep a close eye on that patient, okay? Now, going back to the rhythm, we've established that this is a Mobitz 1, and the next question I have for you is there anything else that you need to do? And interestingly, in about the 5 to 10 people I showed this to, the majority of them pretty much stopped with their diagnosis after the diagnosis of Mobitz 1 was made. But whenever you look at a 12-lead EKG, you've got to be careful that you don't stop after making one diagnosis. In fact, that's true for everything in medicine. You look at an X-ray and you see a fracture, your job's not done. Now you need to look for another fracture. Maybe there's something else going on. Maybe there's subacute error. You get a lab test result and you see one abnormality. Well, maybe there's other abnormalities that you forgot to look for. And on a 12-lead EKG, sure, you made the diagnosis of Mobitz 1, but your job's not done because maybe there's something else going on also. And this is a common mistake in electrocardiography, a common mistake in medicine, that when people make a diagnosis, they stop and they forget about other potential diagnoses. So look everywhere. Don't just settle on the rhythm. Look everywhere. Look in all 12 leads. Look in all 15 leads because you've got some rhythm strips here. Look at all of the complexes. Now, I will tell you that this little beat right there, that's just a little artifact, so you can ignore that. But when you look carefully everywhere else, you go through your method, rate, rhythm, axis, intervals, ischemia, hypertrophy, infarction. You go through all of your different, whatever method is you use. Always use that method with every 12 lead. Even 20 years later, I still do that with every 12 lead I look at. I go through my method through all the different steps. And if I don't, I miss things. When you look carefully, you might appreciate actually that there's something more going on. There's a little bit of ischemic ST depression out there. Maybe a tad bit here. Definitely some ST depression in AVL. And as we've talked about before, when you see ST depression in AVL or a flipped T wave in AVL, that can sometimes be the early marker of an inferior STEMI. So take a look at those inferior leads. I'm sure many of you picked it up right off the bat, but a lot of people out there missed it. And this patient actually has ST segment depression, elevation in the inferior leads, definitely in 3, definitely in AVF, and maybe there's just a tad bit that you see in lead 2 as well. This patient is having an acute inferior wall STEMI, and there's some reciprocal ST depression out laterally, and unfortunately, a lot of people focus just on the rhythm, and they think about the rhythm, but they forget to look for signs of ischemia or infarction because that isn't jumping out at them. And at least half the people I showed this EKG to missed the infarction because they just focused on the arrhythmia. All right. So this patient has an acute inferior STEMI, and just for completeness sake, you remember whenever you're dealing with an acute inferior STEMI, there's 2 other parts of the heart that you need to worry about. You can extend to the posterior part of the heart. You can also extend to the right ventricle. And this is a little bit more concerning because this will change your management. If there's right ventricular MI, then you change your management. You hang fluids and you be very careful about giving any preload reducing medications. And that's probably what was going on here and the reason that this patient was hypotensive. Anyway, Dr. Winters didn't miss this. He sent the patient right up for cath, and this patient had 100% RCA occlusion and a 90% left circumflex occlusion. The patient went up there very quickly, was successfully stented, and fortunately had a very good outcome. So for some of you, this might have been just a simple bread and butter case, but for some of you I know, I think it was a nice little recap of AV blocks, and also a reminder that you need to look everywhere. Look at the entire 12-lead EKG, okay? Don't settle for one diagnosis. Again, let me start from the top here. To diagnose AV blocks, how do you tell the difference between Mobitz 1 versus Mobitz 2 versus third degree? Very simple. Just look at the PR segment. Look at the PR segments, and that will tell you the difference between Mobitz 1, Mobitz 2, or third degree, right? Mobitz 1 gradually gets longer, and then you get drop beats. Mobitz 2, the PRs all stay constant, and there's drop beats. In third degree, the PR intervals are randomly changing. Remember also that emergent treatment is based on the ventricular rate, not the AV block, not on the atrial rate, your decision about emergent treatment of patients. Do you need to shock them? Do you need to pace them? And so on. That's based on how fast the ventricle is going. Who cares about what type of AV block it is? Who cares about the atrial rate? That's more for, urgent or a little while later type of treatment. But emergent treatment, right now treatment, that's based on the ventricular rate. And then again, look carefully at the entire EKG. And then finally, once again, the risk management pearl that I like to hand out whenever I give risk management lectures is the biggest reason we miss a diagnosis is because we make a diagnosis. When you make a diagnosis, your job's not done because there's an awful lot of people out there that have a second diagnosis. And if you simply stop after making the first diagnosis, you may very well miss the critical and life-threatening second diagnosis. It's like the radiologists say, the most common missed fracture on an X-ray is the second fracture. Everyone makes the diagnosis on the first fracture, and then they miss the second fracture because they stopped looking. And I think that's very true for electrocardiography also. The biggest reason we miss the diagnosis is because we make a diagnosis and forget to look beyond that. All right. So anyway, I hope that case was helpful. My thanks once again to Dr. Winters for sending that case, and I look forward to talking to all of you next week. Bye for now.